muscle. For the phrenic nerve, as we can see in this X-ray, is that on the left side, the diaphragm is elevated. This is a motor function assessment chart which is used for each and every patient to document the motor examination finding. And this is not only done at the time of initial examination, but during the regular follow-up after regular follow-ups also. Coming to the sensory examination, it looks very complicated by seeing this photograph, but we just follow a anti-clockwise direction in which we start from C5, which is the outer aspect of the arm, coming to C6, which is the lateral aspect of the forearm and the thumb. Then C7 will be the middle finger, and then finally we go back as C8 will be the little finger and the ring finger going towards the wrist. The inner aspect of the forearm and arm would be with the T1. The upper part of the medial aspect of the arm will be supplied by T2, which is spared if it is not a post-fixed. And the C4 is also spared. So patients, the implication for this is that most of the time the patient says that he has the preserved sensation in the arm, but beneath the level of the elbow, all the sensations are lost. So if you remember the sequence, we won't be missing the sensory examination. And then we can do the sensory mapping also to check which are the areas which are anesthetic and which are the areas where sensation is preserved. This is another chart which where we can document our sensory functions, and this can also be checked at every follow-up. It has to be filled at every follow-up. In the last, we do not miss to check for the triceps, biceps, and the supinatal reflexes, and also the distal pulses of the limb, because this is the pulsations are important if we are planning for a free flap. So apart from the clinical examination, few investigations are also required. Since investigations is a separate talk today, I'll be just touching it very shortly, that we later on go for a nerve conduction studies after 4 to 6 weeks of the injury, and also the electromyography, especially if we are planning for a muscle transfer or we are following it as a case of free functional muscle transfer. Then in the MRI, we can get these findings, and depending upon both the clinical evaluation and the investigation, we now start conceiving our surgical plan. That if it is a case of open penetrating injuries or associated vascular injury, then we need to immediately explore the brachial plexus. But in cases where we could not find any destructive lesion, or if there is only a generalized edema around the roots and the divisions, if the TENS is progressive, and if clinically it is a postganglionic case, then we wait for conservative management with physiotherapy and stimulation. And then we say that we, in general, at 5 months, we must take a decision. Sometimes it is earlier in cases of root avulsions, because we know that the recovery is very poor. And if pseudomeningoceles are present at many root levels, when there is extensive fractures which needs time for healing, then we plan for a delayed exploration. And these are the surgical options which we are going to listen to in our further talks. And in the last, I would say that management of brachial plexus injury, it requires some critical thinking skills, because we have to make reasoned judgments in a systematic manner so that we establish a reliable diagnosis and validate our treatment plan. And the clinical examination or the complete clinical examination is the heart of this skill. And thank you once again to all the organizers for providing me this opportunity.
Yeah, thank you, Veena. I think she clearly told the way of examining the patient who is already paralyzed. That's one. Unlike when you have an individual nerve paralysis, when there is a brachial plexus paralysis, examining groups of muscle is pretty difficult. I think that's one. And the second point we need to remember in the examination is not only we have to think what is paralyzed, shows emphasis, we also have to look out for the donor nerves. It's almost akin to as we learn in plastic surgery. Whenever you see a problem, you also examine the donor site, possible donor sites. So similarly, we also have to examine the integrity of the possible donor nerves. Thank you so much, Veena. And we will move on to our next speaker, Professor G. Balakrishnan, who has been one of my mentors and teachers. It's always said that a child is not a miniature adult. So similarly, a brachial plexus injury in a child is not the same as that of an adult. So over to Professor G. Balakrishnan and to the organizers. Welcome, sir.
It's my pleasure to introduce our teacher, Professor G. Balakrishnan. He's a pioneer in hand surgery, got to receive an award in 2019. Present position is Professor Emeritus, Tamil Nadu Dr. MGR Medical University, Chennai, Managing Trustee of Indian Society of Surgery of the Hand, Indian Society of Microsurgery, and Brachial PLEXUS Group of India. The awards, Oration Awards are the Army Day Oration Award by Armed Force Medical College, Pune, 1998. Sustrita Oration Award for the year 2000 in APSI, and Professor B. Ramamurthy Endowment Prize, Endowment Lecture on New Horizons in Plastic Surgery, Microsurgery, IMA, Trichy 2000, and Coronan Pandalai Oration Award for the year 2003 in APS, Association of Surgeons of India, and Professor R.N. Shinga Oration Award for year 2008, Bihar and Jharkhand Association of Plastic Surgeons, and Gillies Oration Award for the year 2011, EPSICON 2011. Anand Purnik Oration in Mapcon Mahabaleshwar, and Dr. K.R.K. Chaudhary Oration in Plastic Surgery Association, Andhra Pradesh Conference 2011 in Management of Peripheral Nerve Injury, and Thumb Reconstruction Golden Jubilee Commemoration Oration, Department of Plastic Surgery, organized by Department of Plastic Surgery and Facial Maxillary Surgery, Madras Medical College in 2016. The papers presented are 300 papers in national and international level, and the publications, chapters, authors in chapters in 17 books, and editor in volume 2, textbook of plastic reconstructive and aesthetic surgery, 2017. So over to Sir Professor GB, sir.
Good morning, Balaji. Thanks for your nice words. I know Professor DEVADOSS right from 1977 when we conducted our 5th National Congress of Hand Surgery in Stanley Medical College. From that time, from 1977 till today, we are in mutual contact. And I should congratulate him for conducting this conference, also on his innings in practice and his age. He's 5 years senior to me. Now the topic given to me is the birth palsy, clinical assessment, and decision-making in nerve surgery. Now, if you take the pediatric palsy, there are a lot of change, the controversies, even in the name, nomenclature. We call it as Erb's palsy and obstacle palsy. Many obstetricians don't like that term. So David Chong said it is infant obstacle brachial plexus injury and the secondary obstacle brachial plexus injury. And subsequently, the International Federation formed the society or a group led by Howard Clark, and now they formed a new term, neonatal brachial plexus palsy. This is what I'm going to use in all my presentations. When you think of Erb's palsy, all of us thought it is the child palsy because of the affection of the Erb's point. And it was immediately shown there that it should be operated. A lot of still the controversies existing. But not only the Erb's palsy, there are so many clinical patterns are there. The incidence is 1 in 1,000 newborn infants. But if you see the clinical patterns, Erb's paralysis is C5, C6 lesion. Extended Erb is C5, 6, 7, or C8. Total palsy without Horner syndrome. And fourth one is the total palsy with Horner syndrome. 1% of the neonatal brachial plexus palsy is bilateral. And unfortunately, this mother had two child delivered. Both the sisters had a palsy because they are overweighing, and the main mechanism of the
ये
palsy
आगे
is
कर
that
सकते हो थोड़ा
overweight baby blood flows. I think there is some disturbance. Instrumentation and breech presentation. These are told as the common cause of the birth palsy. Now, if you look at these pictures, you'll understand that excessive lateral traction on the neck and shoulder dystocia leads to Erb's palsy. And excessive traction on the arm during delivery causes the Klumpke's palsy. And so the risk factors are large babies, breech presentation, multiparity, prolonged labor, and assisted delivery. So, and the less common causes are sometimes neoplasm, intrauterine compression, humeral osteomyelitis, hemangioma. Everything happens within the womb of the child, mother. Hemangioma, extrasosis of the first rib, cervical rib. So this is one of the other pictures shows how the Klumpke's palsy happens. It's a hyperabduction, as I showed you the other picture, or it could be like a Paracos tumor in the cervical level, or it could be the cervical rib which compresses the lower trunk, resulting in Klumpke's palsy. If you look at the clinical picture of the children, there is a weakness in the arm. Arm is bent at the elbow and held against the body. Many parents think that the child is improving, don't do any surgery. But this is the natural occurrence. The decreased grip strength in the hand of the affected side. There is numbness in the arm, impaired circulatory, muscular, or nervous development, partial or total paralysis of the arm. We always used to say it's a weight-stiff position, and this is what being shown in this picture. You can see this. This is the typical of a Erb's palsy child. We take the history, you must also consider double-level injuries in these children. And they may have associated fractures. There may be a phrenic palsy, which you can identify by just taking ordinary X-ray. Horner syndrome also demonstrates lower trunk injury, and I showed you the reasons. And serial videos to be taken of the child right from the birth to see whether the child is recovering spontaneously or you have to intervene. The clinical examination should be precise. The flexion of the elbow alone is not an indication because it can be caused by brachioradialis. The important for all of us to see whether what is the biceps function. It should be assessed. This will only clearly show that there is a paralysis. The clinical approach should go for the periodic follow-up. And you must take regular photograph. Now that WhatsApp is available, I will ask my patients whom I see the day 1 or 2, go back and send me a video photographs through WhatsApp message every month or 15 days so that I can tell them what happens to the child, whether I should intervene or it is going to recover. The presence of early movements will always encourage the parents not to come for surgery. But it's your duty to look into the picture and then advise them properly. Biceps function and wrist extension are the most important two in the examinations to tell you that this child needs surgery or not. There are some poor prognostic signs. If it's a total paralysis, it's bad. No recovery by 9 months for the child is also bad. Horner syndrome also is an evidence of total paralysis. Does the congenital brachial plexus injury exist? I know none of the cases I have seen, but Alan Gilbert, one of the Narcos meeting, presented that there are some cases, and he has shown 3 cases so far, and I don't think I have seen any of the extra cases. So there is a congenital brachial plexus palsy also available. And now coming to the neonatal brachial plexus palsy and the difference between the traumatic palsy is this. This is very clear from this that how they both differ. Neonatal brachial plexus palsy, mostly supraclavicular lesions, and nerve gaps are present. Scars are scanty, and the regeneration, because less scars and gaps are small, regeneration is possible. And similarly, when they regenerate, there is also a cross innervation leading to deformity. Whereas you take the traumatic brachial plexus or adult palsy, It's always a complete rupture, and avulsion is more common. Intervening gaps are long. Scarring is dense because of the injury. Regeneration is questionable. Cross nervation not possible. And always they have the placid paralysis. Coming to the neonatal brachial plexus clinical assessment, the golden rule of Naraka still holds good. At birth, flail limb, we should not get confused with the tetraplegia where all the four limbs are flail. At the end of 48 hours only you should decide. Also the paralysis limits to one limb, mainly the one upper limb. Either the paralysis may be 5-6 paralysis, the typical hips paralysis, which may recover in 3 to 5 months' time. That's number one. Number two is C5, C6, C7 paralysis. At the end of 3 weeks, it may come down to C5, C6, and they have a residual paralysis. By physiotherapy or by some stimulation, you can get away without any surgery. Whereas in total paralysis, which ends up at the end of 3 weeks into C5, C6, C7 injury, they have a residual paralysis but may need intervention. They combined with the harness sign, there is no recovery, it needs surgical intervention. The assessment should be, lots of things has been done earlier, lumbar puncture, myelographies, and then usually the myelography was very popular in the earlier days. Now the only brilliant diagnostic sign in the as far as the investigative sign is the MRI. MRI with the contrast will prove us which other nerves are affected and give us a good clue to operate. There are some differential diagnoses. Like this, fracture of the clavicle, fracture of the shaft of the humerus, metaphyseal fracture humerus, shoulder dislocations, and also mimic brachial plexus. But a simple X-ray and an examination will differentiate between these two, and you can go for a diagnosis. As I said earlier, if you go to a clinical picture, this is the picture. If you see the upper palsy, there is internal rotation, no elbow flexion, good finger flexion may be there. If you take the total palsy, the arm is flail arm, there may harness syndrome, and then also they have aversion of the T1. Because you have the harness syndrome, you always conclude that the T1 also involved in these cases. Then you have to make a good observation. You must see the length of the affected limb when they come a little late. It's always a little shorter than the normal limb. And you must look for the status of the diaphragm. To look out injury to the phrenic nerve. And look for the harness side. And you must also give a sensory feedback for the children to have some movement. This is very important as a pre-operative preparation. And sometimes they do aggressive physiotherapy because they say, go and do physiotherapy, it all will improve. This is one of such child where they done aggressive physiotherapy. We are not able to abduct the shoulder. And we took an X-ray, you could see the deformed head. Subsequently, we have to operate and release the shoulder muscles to get the abduction. And the aeroplane splint is the one which was recommended those days. It should be never used in our practice in obstetrical palsy. Coming to the spontaneous recovery, the literature says 70 to 80% of the children will recover. That means most of the children must have suffered only hips paralysis. There is no involvement of the rest of the nerve other than 5 and 6. Here there are some other cases what I like to show you. We have seen in our practice about less than 10% of the cases going for spontaneous recovery. This is the child of a doctor with a good exercise and good follow-up, you could see that the child's hand was so flail slowly. Now she's able to catch up. And even here you can see the preoperative hand is good. And subsequently, she is able to catch up the article and the second slide. Here you see the child at the age of 3 months, totally no movement. And then again, we have taken the picture and the MRI showed there is a partial tear of C5 and preganglionic avulsion of the C6. With all this, the child started doing some movement. Hand is good, slowly trying to elevate the hand. This is because of the parents concentrating on the child and then try to give some objects to catch, and then they slowly, this is at the end of 6 months. This is at the end of the 9 months. See, cookies test is positive. This means the child does not need any surgery, we can allow it to grow. At the end of the day, it will become better. This is another child, 22 days. You see that there is no big movement in the prior limb, only the hand movement is present. And at the age 65 days, you can see she was able to lift up, and that flexion is just falling back without any gravity. The child's elbow is flexed and falling on the chest. This happens on day 65. And 120 days, you could see the child is able to abduct to a certain extent, able to catch the object. Here we say conservative management is the ideal, and any loss of further movement can be taken up later. This is possible, but I think this is only possible in simple hips paralysis. And we have to look out for this. And the indication for surgery differs for different surgeon to surgeon. Aaron Gilbert swears by 3 months there is no biceps recovery, operate. Clark from Canada says 6 months. And some people say 9 months. And group 3 and 4 lesions where there is a Horner syndrome and there is no absolute recovery. And then failed cookies test at 9 months. It's an indication for surgery. But still, there are a lot of, mainly 2 controversies. Should the obstacle palsy should be operated? When it should be decision taken? It should be operated or not. The difficulty is the correct assessment of the results. A good result does not mean the same thing for a neurologist, a physiotherapist, a surgeon, or the patient. So we have to evaluate, consult, and then have a group meeting to identify and operate the children. And then when should the repair be done? For most surgeons, we are depending on Aaron Gilbert's statement 3 months. But now we moved on further to 6 to 9 months, depending upon the biceps function and the shoulder abduction. And then this comes only after proper examination. Why you want this early repair? That is a good question to be answered. When you repair early, the regeneration is good, cross nervation and the muscle imbalance are aborted. Provide better condition for tendon transfer. Nerve repair is superior to spontaneous recovery. That was our initial thinking. Now recovery without deformity, because there is no cross nervation, no deformity. And Batters in JBJS 1980 said, none of the infants with recovery at 4, 5, and 6 months of life were normal in long-term function. Children who underwent microsurgery, that means repair of the nerves, at the age of 6 months were more functional than similar infants who recovered biceps function between 5th and 6th month of the age. And he's been a strong supporter of early surgery and repair of the nerves. And coming to the timing of surgery, Zancoli group said biceps recovery happens by 5 months in 75% of the cases. So no direct neural repair before 5 months. This is another school of thinking. Again, you come. Howard Clark said, intraoperative stimulation is important if you see the neuroma and continuity. Prior to 1993, we did neurolysis. Many of them with neurolysis. We also sometimes followed this, but our results are really bad. So now the best thing, if you see neuroma and continuity, even there is some minor action in the hand or the shoulder, we always resect and reconstruct. Resection of a neuroma with the absent fascicular pattern yields better results than neurolysis. Coming to the systematic review of brachial plexus surgery for birth-related brachial injury, the pediatric neurosurgery has published the results. There is no conclusive evidence of showing a benefit of surgery over conservative management. Approaches in the treatment of the patients with the brachial-related palsy injuries, surgery remains a valid practice option given the level 3 and 5 scale of evidence, suggesting the possibility of the benefit of surgery. Similarly, Pondock in 2004 said, patients should exercise caution in predicting excellent recovery shortly after birth That means don't depend on the conservative therapy and seek an active intervention to avoid long-term, lifelong limitations for the individual patient. This was his statement in 2004. And you see in 2015, he said, none of the individual studies provides enough scientific proof that nerve reconstruction is superior to conservative treatment. Similarly, Alan Gilbert has come out with the idea that there is a slight difference between the early 9 months and very late reconstruction. But he is of the opinion that neurotransactions can be still possible after several years, and he showed a case of good result in 7 years in one of the NARACAS meeting at the year 2013. Coming to the next factor is the nerve transfer or nerve repair. Now, most of us believe that we can do a nerve transfer like adult palsy. That's why the International Society formed a board, again headed by Howard Clark, Raymond, and Scott Cauchy. And they said, by nerve transfer, we can get motor-to-motor innervation, early recovery, and no co-contraction. But they are not yet clear about the associated morbidity is not clear. Long-term effects are not known. Donors said morbidity don't know. So in children, they are keeping their fingers crossed about the nerve transfer, and they recommend for primary nerve repair. And conclude my presentation, what we follow for nearly 25 years, that prevention is better. We have to educate or tell our colleagues, obstetricians, that if the baby size is more than 3.5 kilos, better not to go by a naturalis, go for C-section. If the case is a global palsy, we always attempt to do a primary nerve repair. If it's going to be only Erb's palsy, we do a nerve repair at the earliest opportunity. Subsequently, we have seen that there is a shoulder deformity. We do an early tendon surgery like rectus resecting the teres major and latissimus dorsi and leave them to get attached to the teres minor so that they get some good abduction and lateral rotation. And when they come late with internal rotation, we strongly recommend humeral osteotomy for correcting the internal rotation. And thank you very much. Thanks the team for the opportunity.
Yeah. So thank you so much, sir, for very clearly telling us about what are the possible consequences and the approach to brachial plexus palsy. I think to put it in a nutshell, what we have to say is in children brachial plexus palsy, when you compare to adult brachial plexus palsy, children brachial plexus, always some amount of recovery is present. Some recovery is present than adults. And we find that secondary procedures can improve more in children. I think that's another point which is of very important. And the last few slides of Professor Balakrishnan was very interesting in the sense. The question is as to when do you treat these patients? I think we always have to tell everybody, if you see a child with global brachial plexus palsy, which remains global after 3 months, that means that means they have to get on to a person who is interested in brachial plexus. I think that message has to go on. It is no point in waiting a child who has got a global brachial plexus palsy beyond 3 months. They have to at least see them. Not necessarily they will operate it at that time, but they have to see. I think that's one message that has to go on. So thank you very much, sir. And we'll go on to the next speaker, Dr. Terence from Trichy. He'll be speaking on investigating a case of traumatic brachial plexus injury. And how do you investigate a case of birth brachial plexus injury? He'll stick on to investigations. Humble request to stick on to time so that we have finished 1.5 hours with 3 speakers. And we have 7 speakers to go. Thank you so much, Terence, for joining us.
Thank you, sir. Thank you for your wonderful introduction. I can skip my introductory talk considering the time duration. These are my disclosures. I wish Professor A.D. sir a very happy birthday. And this was the long association with Professor A.D. When I was there in Madurai. I just asked him, requested him to write an editorial. I think hand surgery, hand injuries are very close to Professor AD. So he immediately wrote this article and then he sent back to me. In that, he mentioned about Professor Avi and his contribution towards hand injuries. And he said it's about the 7 wonders of the world. And this much is his close association with the hand injuries. I also thank Dr. Satish for this wonderful contribution. A small contribution to the field of brachial plexus, which I feel is fascinating for me. This book is going to be released in 2023, which has all the nuances directly to the brachial plexus. We don't have any descriptions. It will be a tips and tricks and technical aspects. I strongly believe that there are 2 eyes to investigate. One is the clinical finding, and other is the imaging. As described by Professor Anil, this is the one area which distinguishes between the preganglionic and postganglionic. This is the distal ganglion, which is the cell body of the sensory nerve. If the lesion is distal to that, you'll have different finding in the imaging and also in the nerve study. If it is something proximal to it, you'll have a different finding. This is what I'm going to concentrate on it. The challenges in investigation as described by, as shown by Professor Anil, the orientation of brachial plexus are not clear or not parallel, something different. C5, C6 there, and C7 like which has the orientation is there. You see the C5 is here, C6 is there, and C7 is somewhere behind this, and C8 is a little posterior to it. You don't believe that it will be in a parallel line. If you think that, then you are directly going to hit the subclavian artery. The problem in investigation and also in conclusion of investigation is that it's quite complex. The brachial plexus does not have a parallel way, it's an angular path, and multiple interfaces do have a problem in imaging, so that we need to have a very high resolution imaging and also an ability to rule out all those contrasts. The 2 domains, sir asked me to talk about when, what, and where. So what's out and what in, meaning to say that which is working and which is not working is differentiated or helped us to investigate by the motor testing, sensory testing, also some of the sensory evacuation. This is how motor study is done during our motor conduction and nerve velocity. Once you stimulate the particular portion of the nerve and the muscle, you can see the reading there in there, where you get a curve, which is the significance of the contraction of that particular muscle. This is how we record the motor velocity. Similarly, we also do for investigation. When to do the testing? When should the electrodiagnostic studies should be done? We all know that valerian degeneration it ends by 2 to 3 weeks. And also these action potentials, they come down by less than 3 weeks post-injury. I think ideally it should be done around 3 weeks' time. And this is one important finding from the sensory nerve conduction velocity, is that if you have a sensory nerve action potential plus snap, if it's normal, I think I said the lesion is somewhere proximal to the DRJ, meaning to say that you have seen the first slide where DRJ is intact, that's the cell of the sensory nerve, that is intact, something avulsed from the spinal cord, it means to say that's a preganglionic injury. If the injury is distal to DRJ, then you will have findings that is similar to postganglionic injuries in the EMG and also the image. Roughly, if you put together in a mathematical table like this, if you want to find which level of root is involved, C6, you will say that the squishy nerve has reduced or absent sensory domain, sensory action potential. If you find a snap in these particular levels reduced, can directly direct you to these root, this much root levels. T8, of course, the sensory aspect of the digit. Similarly, the motor nerve conduction. We all see the report from the neurophysiologist and don't understand what's happening there in the motor conduction. So all we need to understand is that the motor neuron, the action potential is something like related to the axon, and the output or the axon is the output or the potential or velocity is coming from the nerve, which is contracting or able to contract the muscle. It has some value, it has some action potential. If the axon is intact, we'll get some good normal value. If the axon is not intact or injured or completely damaged, you'll get an absent value. This much is the very basic understanding for any postgraduates or anybody here who doesn't understand what is a CMEP or what is SMEP. You need to understand that nerve needs to be activated, and the nerve has to go and make the muscle to contract and give some sort of amplitude. If this is lost, it means that the relationship between the nerve and the muscle is lost. It can be either a preganglionic or postganglionic, or it can be rupture, which will come across in the coming slides. This is a slide or test which closely correlates to the particular level of injury. If you do a motor domain testing, if you do a triceps testing, it correlates to the radial nerve, similar to the posterior cord, similar to the middle trunk, and somewhere it correlates with C7 nerve. So approximately, this table helps you to differentiate or to say that which level or which root or which cord, which trunk is involved. Such is a very helpful electrodiagnostic study. Needle EMG is very reliable because once you put a needle into the muscle and see the contractions, you can differentiate whether it is working or not working. Working is something a denervation. Not working is denervation. Working is something is normal or reinnervation. See, this is a normal triphasic pattern, and you have 5 to 15 millisecond duration. It should be something like a crisp. It should not be something like a delayed or short, which we'll see here. See here, this is a EMG finding. Obviously, you can see very sort of fibrillation, something like an ECG, you see fibrillations. Something these fibrillations meaning that there's a complete muscle denervation, meaning to say that there's a complete absence of any action in the muscle. That's denervated. Can be a preganglionic or postganglionic. Similarly, if you see the improvement in the triphasic wave, which is good, but it is slowly prolonged, meaning to say that these muscles are reinnervating. They are immature, trying to get mature. So this is something a bad muscle, not nervated, denervated. This is something reinnervated. This much is the news from the EMG. I think this will help you to understand or prognosticate the treatment and also the outcome, assess the outcome. Similarly, there's a question from many of the audience. Can I say it's a brachial plexus traction injury and will it recover? Of course, there are some certain situations where there are traction injuries. How to differentiate traction injuries using the electrodiagnostic? So initially 6 weeks, you'll have all those sharp waves and fibrillation potentials. But then if you could stimulate the nerve distal to the injury, it will be normal. This is what differentiates between the neuropraxia and the axontosis. Preganglionic lesions, most of the previous talks correlate or they overlap. I think the overlapping is very good because it gives a clear message. You know, this, if you want to clearly delineate C5 root injury, you stimulate the paraspinal muscle and also the serratus anterior. If you find any denervation, it says that the rhomboids are not working in an EMG. You say it's C5, paraspinals are involved along with the serratus anterior. Is that something dots proximal to DRJ, something like an avulsion injury, put it as a preganglionic with the normal snap. These are the tests which were done by Landy in 1918. Very much scenario we have seen that the nerve looks normal intraoperatively, but then you do not know whether it is connected proximally to the CMS. So what he did is he stimulated intraoperatively, keeping an electrode in the opposite cortex, parietal lobe. If you could find that the proximal portion avulse is stimulatable when you get the response here, it means that there's a continuity from the spinal cord to the proximal nerve. It's not a avulsion. So we can do a nerve grafting in between the gap. The limitations are usually done in 3 weeks. You cannot differentiate between different types of Sunderland 4 or 5. And if you have a mixed pattern, a preganglionic or a postganglionic, it's very difficult to differentiate. Similarly, what's the need for this EMG? As I told you in these previous slides, they can localize the lesion. Where exactly is the lesion? Root, nerve, trunk. Similarly, a preganglionic or postganglionic are combined. Additionally, the X-rays, which we have also seen in the past previous speakers, rule out the hemidiaphragm, elevation of the diaphragm, phrenic injuries, fractures of the clavicle, proximal humerus, dislocations are more common to have axial nerve injuries. Imaging is very much made a modality. Zhang found a sensitivity of approximately 90% in 1.5 versus 3 Tesla. 3 Tesla is much better, and you can see this sort of lesion or avulsion in the MRI. Accuracy with the CT myelogram, as discussed with Professor GB, though outdated, but many surgeons, not here in India, they prefer as one of the valid modality of investigating brachial plexus birth palsy, where they can have an accuracy of 95, especially in root avulsion. Much advanced facilities in the MRI neuroimaging. They exactly can see the meningomyelocele. In addition to that, you can see the absence of organ nerves. Again, there's a controversy, a lack of clarity again among surgeons, where one group from Professor Anil Bhatt's team say that if you could see meningocele, it correlates the lower root avulsion. But there is another study from says that approximately 68% of them corresponds to the nerve root avulsion. Even meningocele, they can have intact. This much is the finding. Similarly, there's always a sign called black line sign between the meningeal cyst and the normal subarachnoid. So these are the findings in the MRI. equal to differentiate. In the brachial plexus traumatic palsy, root thickening and root avulsion are significant of post-ganglionic injury, and these things are continuously absent in some sort of subarachnoid hemorrhage, so it's an initial injury investigation. Overall, sensitivity and specificity for avulsion is that MRI correlates with the intraoperative finding. What we need to know is, as a surgeon, if you give an MRI image, you say that this much is the percentage of this much is the finding. Say there's a root avulsion, there's a ganglionic post-ganglionic injury rupture. But we as a surgeon want to confirm this intraoperative. If we do the intraoperative and analyze the MRI finding, more or less they are nearly equal with 94%. Limitations might be a partial avulsion or a motion artifacts. Similarly, in the brachial plexus palsy, CT myelography was considered one of the best modality, but then it has some limitations like difficulty perform, it's overly optimistic, there are some additional complications. Is it possible to do an EMG or NCV in a child? Many surgeons in the West in the field can be done, but there are limitations in doing this. CTM also has other limitations like the intrathecal contrast can cause an infection seizure, though a standard procedure as described by Bertil. Many other surgeons in West, they are still doing the CTM to assess the pseudomeningocele and also the absent platelet. Again, MRI for children is very much non-invasive, non-radiation. It definitely says that the root is thickened or avulsed or absent. Here's a child where the ventral root is avulsed, dorsal roots are intact. The MRI definitely has a very good role. If we compare all those findings, CT myelography and MRI, definitely MRI is much better than the CT. And even the avulsions are highly sensitive to MRI, especially the post-ganglionic injuries. So to conclude, I think a combination of clinical diagnosis, investigations, and intraoperative finding is the gold standard. I don't think there's all or none phenomenon. But these imaging in the electrodiagnostic, they prognosticate, differentiate, they find the level of injury, and of course advises on the treatment also post-op management. Thank you very much for kind attention.
Thank you, Terence, for nicely summing up the needs. The most important thing is the last word that we cannot rely only on investigations. The most important is the clinical examination of the child or the adult. And we have to realize that most of the investigations, both the EMG and the MRI, are investigator specific. And they need excellent equipments. I think both are important. I think the good equipments, good person who reads the scans, or both are very important. And once we have them, I think it's absolutely very, very useful. The timing is only very important. There is no point in doing scans and immediately after the injury. I think many a time we find within about 1 or 2 days they have a CT scan, MRI, and also EMG, repeated EMGs with very short periods of time. I think as Terence said, to have an EMG, at least 3 weeks must have passed beyond the time of the injury. So that's the way we go. So thank you so much, Terence. And now we go on to Sunil Gauba's talk, surgical options in partial traumatic brachial plexus injuries and the outcome that was expected. So this is one field where we can really give very satisfactory outcomes to our patients. And I hand over the mic to organizers to introduce Dr. Sunil Gauba from Chandigarh.
Good morning, sir. Dr. Sunil Gauba is currently the professor of Department of Plastic Surgery at PGIMR Chandigarh, and he's a teaching faculty since 2010. He specializes in facial plastic, hand and brachial plexus surgery. He has more than 40 publications to his credit. He has done invited talks in national and international conferences, over 100 talks, and he has won the multiple awards, the ASPS PSF International Scholar of 2014, 9th IPRS APSI International Fellowship 2015, APSI International Traveler Fellowship in 2016, Synthes Ganga Hospital Hand and Microsurgery Fellowship at 2017, Sam C. Bose Best Research Paper Award in 2018, and he has also received the DGP Seva to Society Award in 2020. Yes, multiple international presentations, and he has done as an invited faculty in Baltimore in March 2017, and advances in rhinoplasty at USA DZF in 4 to 7 April 2019, He has organized various workshops like ISPNS 2017, ASPICON 2014, and multiple cadaveric workshops. There are few innovations to his acclaim, and has bagged many awards like American Society of Plastic Surgeon International Scholar and a number of traveling fellowships, including the 9th IPRAS Ganga Hospital. So with this few words of introduction, I invite Dr. Sunil Gaba to continue with this presentation.
Good morning, seniors, and I really thank Raja sir and Dr. Hari for inviting me this, and Bala, thanks for kind words. I'm going to talk about the surgical options for the partial traumatic brachial plexus palsy. And is my slides are moving? Am I audible?
Yeah, you are audible. You are audible. We see the first slide with the nice
Is it
tree
not
and
moving?
the title.
Yeah. Now it's
Yeah,
moving?
now it's moving. Yes, we see the
Thank you, sir.
anatomy.
Thank you, sir. Yeah. So we have already discussed the anatomy. Just I want to show this picture because this is very important for the surgical anatomy, as already Dr. Terence suggested that how it runs. So whenever we explore, we should always remember the relation to the clavicle. So in supraclavicular area, we usually behind upper trunk, and close to the clavicle upper border, it's the middle trunk, and lower trunk usually goes under the clavicle or in front of the clavicle area. So when we talk about the upper brachial plexus palsy, it's mostly 5-6 or 5-6-7, and C5 roots are mostly responsible for the shoulder abduction, while C6 is for the elbow flexion. This is the rough idea because it gives us it is easy to diagnose when we see these functions, and we can make out clinically that this patient is suffering from these palsies or these injuries. So most of the things has been already discussed. So like clinical assessment there. So what are the important for our surgical outcomes? The most important thing is the duration of injury. This is a really very important factor which affects our outcome. So I will discuss it in the my further talk. And if lesion is localized is a preganglionic or postganglionic, if it is preganglionic, then there is a chances of recovery is less, and also severity also affect our outcomes. So usually we fill this performa before the surgery, and we do examination. So we try to find out which nerves are involved and which muscles and donor nerves are available for us. So what are the aim of these upper brachial plexus injuries? We need to have a shoulder abduction as well as external rotation, and we try to give hand sensibility also, and try to restore protective sensation is really invaluable. But so are we able to give all this? We have to be realistic in this. Patient wants everything, but we have to understand when we are talking about the brachial plexus surgeries and the injuries, it requires multiple stages, and the functional recovery is suboptimal. It is difficult to regain full function of the limb. So prognosis is highly dependent on the pattern of injury, and distance and time to regeneration are the key determinant for the results. So if we are talking about what are the surgical options when patient is having C5, 6 or 7 injuries. C5, 6, 7 injuries mostly affect the shoulder and the elbow, and when it involves 7, it leads to the loss of extension at the elbow, wrist, and the fingers. So what are the options do we have? Either nerve can avulse, it can be rupture, it can be cut, and there might be a neuroma. So there are various options to treat these problems. Nerve grafting was really very common before 2000, and when usually people try to do the nerve grafting, but these days nerve transfer has mostly replaced the nerve grafting in adult brachial plexus palsy, because it has to cover the long distance, as well as there is two nerve coaptation sites, so it leads to the loss of axons. But still, nerve grafting is commonly used in obstetric brachial plexus palsy because distance to cover is less. And nerve transfer is really, after Oberlin has described the Oberlin procedure, is really changed the scenario of the brachial plexus surgeries. And in this, we transfer a normal nerve to the distal injured nerve which is close to the target organ, and it provide the early recovery. But it is targeted to a particular muscle only. And in the late cases where usually motor end plate has been atrophied, we can use pre-functioning muscle transfer as well. So when to do the nerve transfers? Nerve transfers are recommended preferably within 6 months, but can be done up to 12 months. And few studies suggest we can do it up to 18 months as well. Because nerve transfer technique reduces the distance to the target organ, it gives early recovery, and as well as it reaches to the target organ before motor neuron and plate atrophy. So what are the donor nerves usually we have when we have injuries like C5, 6, 7 injuries? So intraflexor donor nerves are the median nerves, ulnar nerve, radial nerve, or medial pectoral nerve, while extraflexural donors are spinal axis nerve, phrenic nerve, or intercostal nerve. So these are the nerves which we can use for the nerve transfers. So nerve transfers are usually recommended if patient reaches to us within 3 to 6 months, preferably, but up to 12 months we can do it. So suppose there is an injury in the C5, 6 level. It means there's no shoulder abduction, there's no shoulder external rotation, as well as there is a loss of elbow flexion, but rest of the hand and the elbow extension is mostly intact. So what options do we have now for shoulder abduction? So here we can use spinal X-ray, which can transfer to the suprascapular nerve, and it will provide us the shoulder abduction. As well as we can do SOMSAX, where we use a nerve to the long head of triceps, which can transfer to the anterior division of the axillary nerve. So it will give supply to the deltoid, and patient can have an overhead abduction as well, and some part of the teres minor, so he can have external rotation. So if we do these two nerve transfer, it really have very good results, particularly in C5-6. And for elbow flexion, as I earlier said, that Oberlin has really changed the surgical options of the brachial plexus injuries. So in Oberlin 1, we transfer the FCU fascicle to the motor branch of the biceps for the elbow flexion. So if we understand that what we require and what are the donor nerves we have, it is easy to apply to the patient. And if it is C5-7, in these scenarios, usually we don't have extension at the elbow and extension at the wrist. So we don't have triceps, so we cannot do SOMSAC here. So people has tried intercostal nerves to the axillary or long thoracic nerve or tricep. So they have used intercostal nerve rather than using long head of the triceps. And again, Oberlin 1 and Oberlin 2 also can be used. Oberlin 2, in which McKinnon described that she used the median nerve fascicle for the brachialis as well. So according to her, it really strengthened the elbow flexion, but it's again a controversial issue. So there are a lot of other nerve transfer has been also described, but what I have described earlier, these are the basic nerve transfers which we should understand, and we should try to perform at least. Those are the minimum transfers when we are encountering with the C5-6 or C5-6-7 injuries. So particularly in C5-6, we can do triple nerve transfer, and in 5-6-7, we can do at least double nerve transfer. But if we can use intercostal or phrenic for the triceps, that is also recommended these days. So now coming to the technical points, I usually use gel sponge, which I place under the nerve in case of spinal extensor suprascapular to make it superficial. And I always use Tenno sutures and always use microsurgical techniques. So in this video, you can see spinal X3 nerve is transferring to the suprascapular, and you can see here there is a one vein running in the anterior surface of the trapezius. It is a real clear-cut sign where you will find your spinal X3 nerve running anterior surface of the trapezius. So once you raise this, and this one is suprascapular nerve, I place gel sponge under, so bring the spinal X3 nerve up to the superficial level, and I always try to preserve upper and medial trapezius branches of the spinal X3, so we can use trapezius later on if we require. So you can see now this deep nerve has come up, and now it is really easy to anastomose because it's very difficult to anastomose in the depth. So another option for the shoulder is one is spinal extensor suprascapular for the shoulder abduction as well as external rotation. The next option is in case of C5-6 is where we transfer nerve to long head of triceps to the anterior division of C nerve. So as earlier in the anatomy described, this is the lower triangular space where usually we find the long head of triceps nerve, and this is the upper quadrangular space. This is the teres major. So here you can see the anterior and posterior division of the axillary nerve. So usually we transfer it, and we usually transfer anterior to the anterior division, which is the purely motor supplying to the deltoid. So by this we can achieve the deltoid abduction. And then Oberlin 1 and Oberlin 2. In Oberlin 1, you can see fascicle of ulnar nerve is transferred directly to the motor branch of the biceps, while in Oberlin 1 and Oberlin 2, where one is combined with the Oberlin 2 as well, where fascicle of medial nerve is transferred to the brachialis branch of the MCN. So here few results where we can see. Here you can see this C5-6 injury where I did triple nerve transfer. You can see the scar of the Oberlin, and you can see the results. If we go methodically and we know what we want to give, we can get the results. This is another patient. In this also you can see the triple nerve transfer has been done, spinal extensor to suprascapular, Oberlin 1, and SOM6 transfer. So patient can get as near normal results, although not normal, because we are just giving the supply to the only targeted muscle. Not all the muscle getting reinnervated here. We have to understand that. So when we do only 2 nerve transfers, what happened? You can see this here, because triceps was weak, so we didn't use long head of triceps. Fairly good abduction you can get, but you can't achieve overhead abduction in these type of patients. So you can see only spinal extensor to suprascapular, you can achieve maximum 70 to 80 degree abduction, because he is compensating from other side. It's 70 degree abduction, and poor external rotation, because studies suggest that when we do these transfers, mostly innervation goes to the supraspinatus and less to the infraspinatus. So these are the things which really affect the external rotation. So here again you can see this is only double nerve transfer has been done. So this is about the simple transfers. Suppose if we get any nerve proximal root intact when we explore the brachial plexus and we found that there is a C5-6 is intact, so we can always use those nerves as well. So in this patient, you can change your plan. In this patient, I have used C5 because I found C5 intact. So I used C5 to SSN and to the posterior division of the upper trunk. And at the same time, I did the Oberlin as well. Why we did the Oberlin this? Because if we do the nerve grafting at the level of supraclavicular level, the distance to the target organ, that is the biceps, it's very far. So at the same time, I did the Oberlin, and suprascapular is close and deltoid is also close to the donor side. So it really helps and it gives encouraging results. So we have to plan according to the patient also. So for that, we need to understand the anatomy and the physiology and what kind of nerve transfers we do. So here in this patient, you can see you have near normal results because we have given the neurotization to the C5 through C5 to the posterior division as well as suprascapular. So, but it doesn't mean that we don't have a problems with these transfers. Usually, sometimes you can see patients have a partial recovery. Like in this patient, you have elbow flexion, but abduction is not that good. External rotation is not there. So we have to follow up the patients, and then we have to think what next we have to do. Like in this patient, again, usually Oberlin 1 has very good results. Elbow flexion is there, but he was unable to do the abduction. So now what we should do in the partially failed cases, or the cases which come to us after 12 months, because I usually don't do nerve transfer after 12 months and it is not recommended, but some literature suggests that we can do nerve transfer up to the 18 months after injury. So if injury level is C5-6 and patient come late, or it is a failed case, we didn't achieve the shoulder abduction, as we have preserved the upper and middle branches of the spinal axillary, we can do EMG and we can find out trapezius is working or not. Then we can do the shoulder abduction. We can achieve shoulder abduction by transferring trapezius muscle. Or for elbow flexion, then we have limited choice in 5-6 like FFMT or bipolar LV transfer. Or when we are talking about the 5-7, these are the only two transfers we usually have. So how free functioning muscle transfer work? Usually we take gracilis muscle. It has got obturator nerve, which we transfer to the one donor nerve. And when we are doing it for the elbow flexion, usually you take thoracoacromial vessels. And here in this, you can see there is a very unusual finding. I got two pedicle in the gracilis. So there you can see there is a 2 pedicle in the gracilis, which is very unusual finding. And we did the one artery, one vein, and both. So usually you have a good results with the gracilis transfers, particularly in C5-6 or C5-6-7 upper brachial plexus. Because if you see this patient is young, why I'm showing all this, if you see all these patients are young. So we do usually age has a major role. And if a patient is thin and lean, then result of gracilis is really very good. Another case of FFMT, you can see patient can, elbow flexion is approximately 130 degree and M3 plus or M4. So now next is the trapezius transfer. Usually we take the trapezius along with the acromion and fix it to the deltoid tuberosity using screws. So this is the patient in which we did FFMT because he presented late to us, FFMT using intercostals now, and then you can see that he was having elbow flexion up to only 120 degree, and because of the shoulder was not working, there was no stability of the shoulder. We did the trapezius transfer, and after that he was able to flex elbow up to the mouth. So shoulder stability really improves the elbow flexion as well. That we have to understand. So we did this study, I think 4 years back, pre-COVID data, and we found that we have done these type of nerve transfers, and it is really satisfactory. We got approximately 65 to 70% results with the SAN to SSN, and Oberlin usually gave us in our case 72% cases. We got the M3 plus power. And then we try to find out our outcome in relation to the duration. We found the patient, those came to us within 6 months, their recovery is very good. Only in 85% cases recovered well, while those are in 6 to 12 months, their recovery is reduced drastically. So again, duration is very important for the nerve transfer. And another factor which we found, the age. If patient age is less than 35, the results are really very encouraging. But as patient get older, then the results varies actually. So that another thorny issue is that, do we really need to do exploration in upper brachial plexus injuries? Is it necessary when we are planning to do the distal nerve transfer? Why to explore the brachial plexus? These type of scenario and this type of discussion is going on these days. But most of the articles suggest that we should do the exploration, and the reason is, when we explore, sometimes we find proximal good nerve root, which can be used for the transfer, and it's really very helpful because proximal C5 and C6 roots, they are usually have a large number of axons, which can give us liberty to do more nerve transfers. So there are a lot of literature I have searched which suggests that is the exploration is necessary or not, but few people are against it, but most of them advise that we should explore the brachial plexus. And neurolysis, actually, this procedure actually, it's a really again a controversial issue. Should we do the neurolysis or not? This patient came to me at 11 months, and we opened, then we found there's some stimulation, so we did only neurolysis. And in the post-op, he had full shoulder recovery but no elbow recovery. So it's really difficult to explain why it happened. So now to conclude my talk, or whenever we are talking about the partial brachial plexus injury, the selecting the right patient and intervening at the right time can give good result in this otherwise challenging injury. And the knowledge of the anatomy and clinical assessment is the key factor for the better results. And exploration is almost always recommended, but few articles propose exploration can be avoided for isolated upper trunk injuries. Thank you. Thank you very much. This is my institute where I work. Thank you very much.
Yeah. Thank you, Sunil, for that impressive talk. No, it's very nice. And to all those who are listening, if someone should say what's the milestone in management of brachial plexus injuries, it's the introduction of nerve transfers in partial brachial plexus injuries by Oberlin. We very well recall the presence of Oberlin demonstrating in the first time when the brachial plexus surgery group was formed. Professor Oberlin and Professor Raimondi was there. I think that really enthused a lot of us to go into this specialty. Thank you so much. And would like to any of the panelists would like to have add any comments now, they are most welcome. And before we move, the next thing we'll be moving on is to Dr. Purushothaman from Apollo Hospital, Chennai. His talk will be Global Brachial Plexus Palsy, challenge, but everything is not lost. So that's the title, because now almost the partial brachial plexus injury is almost conquered. Only thing is that we need to make the people come on time. I think that's the only thing that we need to spread the message. And the global brachial plexus palsy, which they don't recover. No? So now over to Purushothaman for his talk. Thank you, Purushothaman.
Thank you, sir.
Raja, are you able to see my slide?
No, I think short introduction. Wait for a short introduction, Purush.
So we introduce Dr. Purushothaman, sir. Sir is currently the senior consultant, plastic hand and burns, facial-maxillary microvascular surgeon at Apollo First Med Hospitals and Fortis Muller Hospital at Chennai. He was the past president of Brachial Plexus Surgery Group of India in 2017 to 19. He was also the past president of Tamil Nadu and Pondicherry Association of Plastic Surgeons. He is also a PG teacher for DNB Plastic Surgery at Apollo First Med Hospitals since 2005. He is also the faculty of microsurgery workshop at Ethicon Institute in Chennai and has trained more than 250 surgeons in the past 15 years. He has multiple presentations, publications in national and international journals, as well as he has contributed numerous chapters in the textbooks of Indian and international textbooks. So over to you, sir, for your presentation.
Thank you, Dr. Balaji, for your nice introduction. My screen, is it visible? My screen, is it visible?
No, you are visible. Not visible.
Screen?
No, you are visible.
Slide is not visible, sir. Your presentation is not visible.
Is it visible now?
Yes.
Yes, sir. Yes, sir. Visible.
Now?
Visible.
Yes.
Sir, visible.
Not the slide show, but otherwise it's visible.
Is it okay?
It's not the slide show. It's only, it also shows the pattern, no?
So you can click the slideshow option, sir. Slideshow option.
Yeah, I am clicking only.
Okay, sir.
Yeah.
Now?
Illa Purushothaman.
I'll again come back. Able to see now? Are you able to see now?
We see the slide, but then it also shows, maybe it's not in the slide show.
Now?
Sir, kindly click the slideshow option, sir. Slides are visible.
He's clicking only. Click there. Not coming. I think the same issue as Dr. Veena before. Are you seeing full screen, sir, in your screen?
Yeah.
Two slides. Yeah.
Can I go ahead?
Yes, sir. We will increase. So all can increase on the side. There's a fit option. We can, all of us can zoom in and increase it to 150 so we can see the full screen.
Can I proceed?
Yes,
Yeah,
sir.
please proceed, Purushottam.
Good morning, friends. First, I'd like to congratulate and seek the blessings from Professor DEVADOSS on his birthday. And I profusely thank him for organizing this Brachial PLEXUS symposium. And again, I'd like to thank Dr. Rasababdi and Dr. Balaji for including me as a faculty. The topic given to me is Global Brachial PLEXUS Palsy, a challenge, but everything is not lost. This has been already quoted by the previous speakers. To someone who has nothing, a little is a lot. And nowhere in the field of hand surgery is this more true than in global brachial plexus palsy. I owe a lot to these three people, Professor R. Venkateswamy, with whom I am associated for the past.
Slides not moving. We are in the first slide, Purushottam. Now it's okay. Yeah. Now we are in the third slide. Yeah, we see the three joints we see.
Okay. So I am associated with the Professor Venkateswamy for the past 30 years. And it was in 2004 he first organized this brachial plexus live workshop in Apollo First Med Hospital. And we invited Raimondi from Italy and Oberlin from France. And I think most of us were benefited from this conference. And at the same time, this group was also formed, Brachial Plexus Surgery Group of India. And I think at this juncture, I will appeal to all the delegates to enroll and become members of this society. And we conduct once in 2 years an annual conference. We invite international doyens from brachial plexus surgery. So at this juncture, I'd like to invite everybody to become a member of this group. And moving on to my talk, Global Brachial Plexus Palsy. If you look at the distribution of paralysis, this is the statistics provided by Raja Sababdi from Ganga Hospital, and nearly 50% of them will be global palsy. And here they've said 48%, and invariably it will be around 50% or little even more. And most of them will be a all root avulsion. So what is a typical total palsy patient present like? Here you can see left side, he has a complete paralysis, and he has Horner syndrome. That means T1 is paralyzed, and he has a dome elevated in the X-ray chest. You see, that means C4 phrenic nerve and C4 is paralyzed, and MRI shows neuromeningocele, pseudomeningocele at all levels. So this is the typical presentation of a total palsy in our scenario. And what is the aim in such patients? And I always go for a total nerve reconstruction, because I feel a nerve reconstruction is far better than any salvage procedure. Of course, all of us know it's a race against time, and I coin my technique as a all-in-one or a hole-in-one procedure. And those who played golf or know golf will know what I mean by hole-in-one. With a single stroke, we try to achieve the maximum. And the first thing is you have to look for any usable route is there or not, because that will a long way help in your reconstruction. So we have to assess whether any of this route is postganglionic or not. So if there is a postganglionic route like this, injury like this or this, we can utilize these routes. Whereas if it is preganglionic like this, we cannot use this. So with the avenues available like MRI, nerve conduction and exploration, we have to come to a conclusion. And a good MRI is always a very essential, and we have to sit with the radiologist and try to ask them to give a picture like this. This is a normal MRI, and here you can see all the rootlets coming from both the sides of the spinal cord. And here you see a right-sided pseudomeningocele and absence of rootlets on this side. And again, at the foraminal region also, they have to study and see if there is any rootlet that is available through this or not. So for a total nerve reconstruction, what are the recipient nerves I target? For the shoulder, I target supraspinatus, axillary, and if possible, nerve to serratus anterior. And along with that, pectoralis major also. And for the elbow, biceps brachialis and triceps. For the forearm and hand, the whole of median nerve and the radial nerve, all motor branches. So my first thing is search for the donors. We have to recruit minimum 30% of the axonal quantum, and only you can get an M3 result in any of your reconstructed muscle. So we don't hesitate to go to contralateral C7, which can supply nearly about 16,000 to 40,000 axons. Along with that, we take spinal accessory and intercostals about 3 or 4. Rarely, when some of these are not available, we go for C4 motor or a phrenic nerve. So how do we bring it to the affected limb, the contralateral C7? We took this idea from Gu. We have been doing this contralateral C7 from almost 35, 40 years. Initially, he also took it as a free flap. He took one artery and vein along with the ulnar nerve. It's a vascularized ulnar nerve graft, and bring it to the affected side and sequentially connect to all important branches, musculocutaneous, median, radial, and of course axillary is separately innervated from the spinal accessory. So similar to this, we formulated our own technique, and initially we also started taking along with ulnar artery like a vascularized nerve graft, but you add another variable, that is the microvascular variable of artery and vein. So avoid this. Subsequently, you also and we also switched on to the superior ulnar collateral artery based vascularized ulnar nerve graft. Based on this one good artery, you can take about 52 centimeters of vascularized nerve graft. This is what currently we are practicing, and this video clip will show our technique. This is the vascularized ulnar nerve graft based on the superior ulnar collateral artery, and here you can see a good bleeding almost up to the 2/3, and in the end also under microscope you can see a good bleeding from the ulnar nerve. And this will be flipped 180 degree like this to reach the contralateral neck to the contralateral C7. And this nerve, here you can see, as it lies, wherever there is a recipient nerve, one funiculus goes to the axillary, another funiculus go to the biceps, nerve to biceps, another to brachialis, and the distal line we divided into two and gave it to anterior and posterior trochleus nerves. So like this, we targeted 6 nerves. Along with that, we also did the spinal axillary to suprascapular. So we targeted 6 nerves, and this is a typical patient which we operated in 2005. Here you can see this is about 3 or 4 years post-op. All of them had a good shoulder or elbow, but hand, there was only a bizarre recovery in the flexion as well as extension. There was no functional improvement in hand. So subsequently, we thought we had to add more axons into the injured area, and here we targeted 7 nerves. We added the intercostals. We took 2 intercostals and added them to triceps, and the remaining the same pattern we followed. And this is the result after about 3 or 4 years. Good shoulder, good elbow, a good wrist extension, and the same patient video. If you see, he had good voluntary control. It is not controlled by his opposite hand. He had a good voluntary control of his shoulder, elbow, wrist extension, finger extension. But unfortunately, he did not develop any finger flexion or wrist flexion, but he was using it as a supportive hand. And here you can use it as a supportive hand. He was started writing with his left hand, and he was using it as a supportive hand. So get more hand function, we thought we have to innervate more branches of median and radial nerve. So we took the entire median nerve so that he gets some sensation also, and all the motor branches of the radial nerve just above the elbow. So along with that, we also included some more intercostals. So nowadays we take about 3 to 4 intercostals. 2 of them will go to triceps, 1 to pec major, and 1 more if we connect it to serratus anterior. And after doing this, we thought still we are not able to get a good hand function. We thought just like what you see in vascular repair, proximal steel phenomena. The proximal, the first nerve root which is getting an axon, can rob all the axons. So the axillary and biceps brachialis, they do develop good recovery, whereas hand suffers. To avoid this, we started using separate nerve grafts for axillary, biceps, and brachialis, and use vascularized ulnar nerve graft only for median and radial. We started doing this after a couple of years, but here, unlike the earlier patients, the elbow did not recover as we anticipated. A good shoulder and elbow, some amount of finger flexion, some amount of triceps was there, but he failed to recover elbow. So we want to have a definite elbow function. So we thought we'll use dual source for biceps and brachialis. Use one nerve graft for biceps and use the vascularized ulnar nerve graft. You take one funiculus and connect to brachialis, so that you have a dual source. The root also can be dual, the source also can be dual. And subsequently, we were able to give a definite elbow flexion in all these patients. Here you can see where we have done a dual source for elbow, very good elbow flexion. So along with that, because we are taking the vascularized ulnar nerve graft, the ulnar innervated FTP will not recover. So to avoid this, we started tagging the remaining ulnar FTP to the median nerve innervated FTP. And along with this, because they are not going to develop any intrinsic function, we started doing the static split FCO opponents plastic, so that the thumb comes nicely forward and is able to meet the other fingers. When the other fingers flex, the thumb will be in a position to meet them. So this is our current scheme. So we target 9 nerves, 4 for shoulder, 3 for elbow, and 2 for forearm and hand, along with static opponents plasty and FTP tagging. And this I call it as all-in-one or whole-in-one reconstruction. And what kind of sensation do they get at C7? Here you see, this is about 3 years post-op. My colleague, Dr. Girish, is asking for whether he is able to feel, and he is touching the median nerve innervated area. And now you see he is touching, he is saying yes. But again, he is asking, how does he feel? And he says he is able to feel on the opposite hand. This is the kind of sensation we do get in contralateral C7. So now I'll show you about 3 cases. And here you see the right upper limb he had a global palsy and the whole thing was reconstructed. He is able to nicely swing his arm. And if you look at the right upper limb, it is not like a paralyzed limb, almost like a normal limb he will have. Elbow, very good and independent, almost independent function. There is no, he's not using his opposite hand, that is triceps. Of course, he has no wrist extension, but here you can see he's able to get some finger flexion. Thumb is also in a good position. Once they get into this kind of recovery, we give them a good outrigger and strengthen the flexus. Here's another patient. This is also about 3 to 4 years post-op. A good shoulder, good elbow. But you can see he uses his right hand to stimulate or initiate that function. He's still not independent from his opposite limb. And to our surprise, we can see a very good voluntary control of both supination and pronation. Very rarely we get a recovery like this. Once they get a good finger flexor, we give outrigger like this and further strengthen them. And this is my last patient. And this patient was able to incorporate his hand for all his bimanual activities. And to our surprise, even the thenar muscles recovered in this patient. You can see a good thenar muscle activity in this patient. You can see this is mainly because of thenar muscle reactivation. And he went on to be almost independent. left hand functions, and he was able to incorporate all his daily activities. He can lift a chair, and this chair weighs about 9 kg. You can see he can easily lift his chair, and he was able to incorporate. This is one of my best results. I got it in my series. This we presented in IJPS, the all-in-one or whole-in-one repair for adult total brachial plexus palsy. And in case if they don't, we wait for nearly 3 to 4 years. If the wrist is unstable, we go for a wrist orthosis. If the thumb is not in a position, then we go for a static FC operantsplasty. And if there is any failure or recovery of biceps or finger flexion, we go for either breathless pre-functional muscle transfer or even a double muscle transfer. The advantages of my procedure is the maximum neuronal quantum is devoid of injury is applied. And the single stage procedure with a stable shoulder and elbow with a functioning and including sensation is possible. So the recovered patients, they always see their limb is almost like a normal looking limb. It is not like a parallel limb. And the neurological pain is also less when compared to unoperated patients. And we are able to rehabilitate them well and try to incorporate that hand in their daily activities already. But the disadvantages are donor morbidity, but it is not very much. Of course, the brain plasticity has to play a big role in incorporating his recovery. And voluntary control, many of them don't have, at least for about 3 to 4 years. Only after that it comes. But main disadvantage will be a little unpredictable results. I get this kind of recovery only in about 25 to 30% of my patients. So by adopting this concept, all-in-one or whole-in-one reconstruction, we can nail the problem of total palsy and win the race against time. Thank you.
Thank you so much, Purushothaman. It's one of the heroic efforts to salvage global brachial plexus palsy, where you're doing a lot of work to get the desired result. Thank you so much for your innovative efforts. I think I recommend people to read the article in the IJPS, which has been published. And next is my talk on when people come late. What is it? Because starting from the first speaker to Purushothaman, I think everyone has said the surgery for brachial plexus is a race against time. So when you lost time, when people come to us after losing their time, is there anything that we could do? I think that's the talk. That is the talk which I have to make. So I think that while I'll get my screen now.
Sir, it's time to introduce you, sir. It's my great privilege to introduce my teacher and guru, Dr. S. Raj Savabadi. He's a chairman, Department of Plastic, Hand and Reconstructive Microsurgery and Burns, Ganga Hospital, Coimbatore. He's a president, Asia Pacific Federation of the Society of Surgery of the Hand. He's a Secretary General, International Federation of Societies for the Hand of the Surgery of the Hand. He's a editor-in-chief, Journal of Hand Surgery, Asia Pacific, and Sushruta Guha, Professor in Plastic Surgery and Wound Healing of the Royal College of Surgeons at Edinburgh, UK, 2016. He's a visiting professor in many of the universities in US, like Mayo Clinic, Yale, Michigan, and Washington University, Singapore, Sri Lanka, and Bangladesh. He's a vice president of Diabetic Foot Society of India. He's a past president of various associations, Association of Plastic Surgeons of India, Indian Society of Surgery of the Hand, Indian Society of Reconstructive Microsurgery, International Trauma Care, Indian chapter, and Brachial Plexus Surgery Group of India, 2011 to 13. He had about 180 paper publications and 51 author of 51 chapters in book, and awards, academic awards 105 and orations 41. Sir, with this, proceed your talk, sir, please. Thank you.
Balaji, are you able to see my slide, Balaji?
Yes, sir. It's able to see.
Yeah. So the title of my talk is the late presentation. The first question is what exactly do you mean by a late presentation? The scope of the talk would be that if we see a brachial plexus injury patient who has not taken any surgical treatment for more than 9 months and has not recovered, so that would be one. And also, I would like to include patients who have with failed outcomes. But I think any surgery you do, we get the outcome in about 1.5 years, 1 year. And then if they have failed outcomes and then they come to us, again, I would consider them as a late presentation, because so that it will give a completeness of this presentation. What's the problem when they come late? The first problem is that the muscles have wasted away and the motor end plates are no longer stimulatable. I think they give a point whereby the time from the time of denervation to reinnervation must be 18 months. And if that exceeds, that means that even though the nerve endings go there, the motor end plates are no longer stimulatable. So that's one point. Second is this, in this time period, secondary joint changes in the joints may occur. Rarely you find a patient with a brachial plexus patient who comes late with a shoulder elbow joint stability, but then they may come with MCP joint and finger joint stiffness. The solution is that we need to introduce new power into the system, and most of the time we use free functioning muscle transfer as part of the treatment plan. So what is an FFMT, or a free functioning muscle transfer? It is a microsurgical transfer of an expendable muscle with coaptation of the motor nerve to a functioning nerve in the recipient side. So the two things are important. One is microsurgical caliber. Second is that you must have a functioning nerve in the recipient place. And the muscles that we commonly that are used are gracilis and rectus femoris. Rectus femoris is a bipinnate muscle, and gracilis is a straight muscle. And people say that we could have a bipinnate muscle, we could have strength must be higher. They could be stronger. But then we always use gracilis, because you will find that you really want to place the elbow or the hand in the position that you want to use. Not that you really require a great amount of strength, but I think you should be, if you are able to use reasonable amount of strength, that's fine. And we always use gracilis. So what's the protocol when we see late? So we need to have some priorities, and then our priority is that first you must get an elbow flexion. You must get elbow flexion. Without it, no point in getting anything in the movement in the hand. Second is that when we get an elbow flexion, we fuse the wrist and the first CMC joint in the appropriate position, so that we could have the fingers to move. Because if you have a flailed wrist, whatever you do, what will happen is the muscle that you use will first stay on the flailed wrist, and then it won't be transferred to the fingers. So we always fuse the wrist and CMC joint. And even though if you have used spinal axillary, some trapezius will be present. We again use the trapezius to deltoid for shoulder abduction and stability. And the third stage is the most challenging stage, because you need to get the fingers to move. If they don't get the fingers to move, whatever you do, they only work as a paperweight. So FFMT for finger flexion, for what is that? See, what we do is we have had a patient, the same patient, we have had a FFMT that we have had. And because of that, he has been able to do a finger, he is able to do an elbow flexion, he is able to do. And then for getting elbow flexion, what we do is we use free function. The gracilis is what is used. And then what we found was he has got a reasonable amount of elbow flexion, and that's the amount of finger flexion that you could get. So we use the finger flexion. For finger function, we have used the intercostal nerves we have used. And what do we do? Because these people, they can only flex the fingers, but then actually the finger is in this type of position. So unless you are training them with extension, passive extension, the flexor power will not improve. So what we do is an extension glove, whereby we have a strap in the wrist, and we have got elastics which passively get them into extension. And then we strengthen them for flexion. I think this is very important. So what can a patient do with what he has got? I think this is the thing you have got. You see, now he is able to hold it. I think it's just not a paperweight. I think he is able to hold it. And we'll see with subsequent patients as to how much they all can use. And then this patient also can use still more he has used. See now, is it? Now you see that he's able to use this. Taking up to that point, he can use it. And he's got a weight about 500 to 600 grams he got. And now you see that he has got it, he can able to push it forwards. So that is quite possible. And they all use it as to move things that they can use independently. If you ask them now that they could use this much amount of it, could use. And you can also use it after getting that. You can also use to cycle. I think this is ultimate result. These guys can get. They use it to hold. I think that's the most important thing that we have. We see another patient who has got a global brachial plexus on the right side. This is a free functioning muscle transfer that is being done. When the free functioning muscle transfer achieves about M3 power, that means against gravity that he gets, we immediately fuse the wrist. If you don't fuse the wrist, the power that is exerted by the elbow flexor, it gets wasted. So by fusing the wrist, what happens is the whole of the forearm and the wrist, they become one unit. So once it becomes one unit, and once it becomes one unit, he is able to know the elbow flexor could easily be strengthened. I think this is one of the operations which you would hardly recommend. So now use the second FFMT for elbow finger flexion. See, now you feel the donor areas on both sides, both gracilis have been taken. Then this is the type of injury you can get. And when these people use it, you will find they always know a little bit amount of bowstringing will be present, but it is not quite useful. So now you get another patient where you got a brachial plexus injury on the left side. You use the first FFMT and then get the elbow flexion you get. And then we train them, before doing the next one, we train them with magnetic gloves. Magnetic gloves is one whereby we use a sort of magnets on the volar side, and they use corresponding points in the opposite side so that we get them, strengthen them. So this is we use, and we could load them with what they could have so that the elbow flexion gets really, really strong. I think that's the advantage we use. So here you find that they got magnets inside. So it attaches, the other side is also has got a corresponding magnet, so a hold. And when we're doing this, we strengthen the elbow flexion that we get. And then the elbow flexor becomes so strong, we continue to use that as for the finger flexion. So now we opened up again and we did the FDP. And then here is the facial latter that has been used. Now we attach it to the same elbow flexors that we have got. Sometimes even we disconnect it and attach it to facial latter, and we get it. So this could get a real good finger flexion. I think this has been we have been very happy about this. That's the place where we used it. But then if you have to achieve this result, we need to have something which passively extends the fingers. So that's very important. See, that's the way we use this thing. So you will have a person to flex the fingers, and there is a patient who can do this. He's able to cycle. He's able to hold this thing. He's able to hold. So this is very important. I think this has been one of the things which we have been very happy about is biceps to FDP. And this has been more useful to us where people have come early to us and where we have used a spinal accessory to get them to musculocutaneous, and where the biceps itself has recovered. So it's much more easier option to do. So this patient has done that, and then after that he has got married. What is really important is that what the patient does with what we have given him is what is going to almost independent now. So our current preference for finger flexion is to use the recovered biceps to FDP through a facial attack graft. It would involve appropriate use of the gloves, training, and supervised therapy. I think that's very important. I think you need to use it really, really hard. Physiotherapy is very important. You require a good team of plastic surgeons and orthopedic surgeons working together. So I told you about the gloves, and this is what is the gloves. Mala pressure governments, they are working closely with us for burns patients, and then we hit upon this idea. What we do is this gloves has got magnetics that are incorporated in the gloves. And to train them, we have another sleeve that is put on various things like pen, like bottle of water, so bottle cap. So once this happens, it just catches it, and we train up the elbow flexion. The elbow flexion is almost got to 4+. We can bring it. See, these are magnetic gloves this boy is using, how to make may make it to use the tumbler and all that use. So Ganga Hospital experience with FFMT is from 2006 to 2018. Hari did a study. We had done about 168 cases of free functioning muscle transfers. Of course, these are all facial palsy is small. And for the elbow flexion, I think for adult brachial plexus palsy, this thing, but most of them is used for finger flexion is only 58, and for elbow flexion is 104. So now technical considerations about how do we do this free functioning muscle transfer. It must always take an island, because the skin amongst this arm and the forearm is shorter, it is really atrophied. If you just have the muscle, then its closure becomes difficult. Any tight closure becomes, so always take an island. You identify the pedicle, and the nerve length, operator nerve is about 8 to 10 centimeters. Suppose some of the speakers said they got 2 pedicles. And we always find the most dominant pedicle is the one which accompanies the nerve. So we are able to get about 8 to 10 centimeters of the nerve, which is quite adequate to reach the, and we do mark the muscles, the length, so that when you go back into the arm or the forearm, we keep the same length of the muscle fibers is maintained. And the fixation has to be very adequate. It has to be fixed to the clavicle. And it is the clavicle fixation is done by drilling holes, 1.5 millimeter KY, and use PDS, multiple PDS sutures, and then anchor them very tightly. And distally, the tendon, we always use it to attach it to the biceps tendon. If you use it distally, the elbow flexion is that is more distal you go, that means the flexion will be better. But then we want to really strengthen the elbow flexion so that we want to use them subsequently. So we attach it to the biceps tendon. That's the position of the patient how we operate. And most of the times now, it's the thoracoacromial vessels is what that is used for this, and the thoracoacromial vessels used, and we use the cephalic vein is the common vein that is used. And if you're when you're going for the second time, if you are using that, we identify the third and fourth, fifth intercostal nerves is the ones that is used as our motor fibers. The vessels are identified in the axilla. And the third and fourth, fifth intercostal nerves are the ones which are used. The intercostal nerves are found at the lower border of the ribs. And our first experience of how to identify the nerves, we got it from the first course that was held in Madras when Dr. Raimondi did that course. And he was asking us to be very cautious enough to use the bipolar. And he said, and other thing which he said was, you must have absolute problem in hemostasis. And that again was that in his mind, any problem he had, he said, always he was very patient to identify the nerves. And we stimulate the nerves to find out, to verify that it is stimulatable. And then we take this nerves. And whenever we use this in intercostal nerves, we use glue also is used. So these are the 3 intercostal nerves that are taken. The muscle will be attached, and that's the way it will look. The 3 intercostal nerves spread out back, folded back, and attached to the intercostal nerves. So the important thing is we need to keep everything ready before detaching the muscle, because ischemia time is very, very pertinent when you do an FFMT. When you use a gracilis muscle for cover in lower limbs, it doesn't really matter even if it is longer, but then the longer the ischemia time, lesser are the functioning muscle fibers that are in the muscle. We have to keep it within an hour. Most of the time, our timing is about, total time is 50 minutes. So you need to keep everything before this. And vascular anastomosis must be done first before doing everything else. So this again, intercostal nerves, we use a glue to attach it. So the final position will be this. That is, this will be the position where how we have the island is incorporated into the area. And this is the immobilization that we use, and we discharge them at 14 days because it's a free flap. Post-operatively, electrical stimulation, we teach them electrician, we give them the machine. Every patient takes home a machine, and we teach the attenders as to how to do this. And later on, we do a remote monitoring of patients. This is a patient of Siliguri. I think we used it by WhatsApp, and we keep monitoring the patients very regularly. And it is quite possible now to come up to this level. I think it's quite possible to come up to this level with this system. One, you must get a good elbow flexion. I think that's the key. Once you get a good elbow flexion, then we stabilize the shoulder and stabilize the wrist. Stabilization of the shoulder is by doing a trapezius transfer again with the functioning trapezius, whatever is left. And stabilization of the wrist is by doing an arthrodesis of the wrist and the first CMC joint, because we are going to get only one motor and they are going to do the finger flexion only they are going to do. And what we are going to get is this. To strengthen this, you require a good physiotherapy department. For about 9 months, you need to strengthen it. And then you need to augment the muscle to use it for the finger flexion. And that's our brachial plexus team, a combination of orthopedic and a plastic surgical team. So we have found this pathway is the most useful one for this. So thank you so much, Balaji and Satish, for giving us this opportunity. And once again, we thank Professor DEVADOSS for the opportunity that is given to us. And we pray God Almighty to continue to wish you good health, sir. Thank you so much, sir.
Thank you very much, sir. You have very well give a key points to that how to manage the late presentation order brachial plexus palsy, and very useful technical tips for the FFMT, sir. Thank you very much, sir.
So thank you, Balaji. And now we go on to the next presentation. It's also from our own unit, Dr. Hari Venkatramani. Hari will talk about nerve surgery, surgical options for both brachial plexus palsy and the outcome that is expected. So we have been talking about adult brachial plexus palsy, and Professor GB has given this thing about the clinical this thing and the pathways that are currently practiced. And Hari will most probably be talking about more about the technical aspects and the outcomes that we can expect by early intervention in both brachial plexus palsy. Over to you, Balaji.
Yes, sir. It's a time to introduce our speaker, Dr. Hari Venkatramani. He's a senior consultant in the Department of Plastic, Hand and Microsurgery, Ganga Hospital, Coimbatore. His current positions are: is a president-elect in the Indian Society of Peripheral Nerve Surgery, secretary in Indian Society of Reconstructive Microsurgery and Brachial Surgery Group of India. He's an associate editor in the Indian Journal of Plastic Surgery, Plastic and Reconstructive Surgery, and International Microsurgery Journal. The awards he received are APSI Dr. Raj Sabhavati Leadership Award in 2020 and Treat Prize Award APSI and the Kilner Essay Award in APSI and Professor Robert Auckland International Traveling Fellowship of ISS and RN Shinka and AH Antia Publication Award. He had 15 book chapter publications and 86 peer review journal articles. The presentation, over 200 international and national presentations in his credit. Sir, it's over to Dr. Hari, sir, please.
Hari, you're mute, Hari. You go back from the first, you're in mute. Tabi.
Is it okay now, sir?
We're not able to see the screen, Hari. Now it's coming. Now the screen is seen. Yeah.
Yes, sir. So, thank you, Dr. Balaji, and many happy returns of the day to Professor DEVADOSS. Thank you all the seniors for this wonderful opportunity. So, Professor Balakrishnan has very elaborately now told us about the differences between the children and the adult, and we have also seen the reconstructive options in the adults. So, as Professor Balakrishnan said, in the children, very rarely we'll have as much severe nerve damage as in adults, as it is a low energy injury, and also there are a lot of cross connections. The key factor in birth palsy is that the nerves in the children have got more connective tissue, so that is why they are much more prone to the stresses and strain. So most of the time in children we'll find nerve ruptures as compared to avulsions. So these are the questions which any parent asks, and even the referring doctor or the pediatricians or the obstetricians ask. When to refer, when to operate, how late is late, what are the recovery which you can tell the parents, what are the techniques available, that is for our specialty, what are the outcomes we can expect, and what are the secondary procedures which will be dealt in the subsequent talk. So when we see a child with a flail limb, 3 to 6 months, as Professor Balakrishnan said, very likely there is possibility of complete spontaneous recovery. So these children are ideal candidates for surgery, and this is what we also felt. If you see the picture on the inset here, there is dimples present on the MCP joint, and this is a very important clinical finding. This means the intrinsic, there is no intrinsic recovery or complete avulsion of the T1 root. So first child we operated also at the time when Professor Raimondi and Professor Oberlin came to India, and this was a case of global brachial plexus palsy. And with the available literature search which we did a neurotization using nerve graft. We found one good route, and this is late Dr. Bhatt. At that time, doing a brachial plexus palsy was a big sort of event. We had a central line, and these are the lines which were there. So doing it is what at that time looked very scary, and then over a period of time now it has become very streamlined. But still, when you start operating on babies, the level of anesthesia care has to be very high, because brachial plexus in children is one of the surgeries which takes a long time as compared to all other pediatric surgeries. So we explored the child and then put a lot of nerve grafts in the available route. And we actually lost the child for follow-up. 5 years since the child came to us, and this was the recovery which we saw. And we are very happy and surprised to see with that amount of nerve graft, we got good shoulder abduction, good elbow flexion, but a weak wrist and hand, which subsequently underwent a reconstruction. Around the same time, we found that many children, when we see at 3 months, as seen here, have no recovery. At 6 months, they start getting some recovery. And then a lot of papers came up which said that 80% chance of a child who has no elbow at 3 months can get recovered. So we became a little conservative and started operating them a little later. So this is the same child which we saw at 3 months with no elbow flexion, had near normal recovery. We did not operate on this child. Brachial plexus surgery group, we conducted the meeting in 2009, and this was sort of turning point. Here we have Professor Alex Muse and Jorge Clifton, Professor Raj, and all our team members. After this, and we came up with this management protocol modified for our Indian conditions. So we'd like to see the child at 4 to 6 weeks. If there is a global palsy, as I presented the first child, we operate at between 3 to 6 months. So around 6 months we explore. No biceps at 6 months, but good triceps, again we explore. But good biceps and moderate amount of hand function is there. We monitor them and have a close follow-up. But then if there is good triceps and co-contraction, we give Botox. And on exploration, what do? We can put nerve graft. Unlike the adults, we put extensive grafts in children and get good recovery. And I will be elaborating on that. Nerve transfers, if you see them late or no roots are available. And then overlaid transfers in late presentation. So we will see with 12 examples all the various scenarios. So here is a child, we explore, we stimulate the musculocutaneous nerve. So this child, if you stimulate the musculocutaneous nerve with a low amplitude, we start with 1, we see there is good flexion of the biceps. So this proves that the biceps will have spontaneous recovery. So in these children, we give Botox to the triceps. So that became our protocol. So we later on did not explore the biceps. We can feel it, and if we feel a good biceps, or if the child already has an EMT NCB done, which shows re-innervation of the biceps, we straightaway give Botox to the triceps. And this is the amount of recovery you can get after Botox injection. No other nerve surgery was done for this child. Now we come up to C5, C6. So upper brachial plexus palsy. If you see here, it's a classic Erb's palsy. The child has got a strong triceps, good hand function, a weak wrist flexion, and no shoulder and elbow function. So here we find on exploration rupture of C5-C6 root, and we take grafts from both the legs. In a child, you can get 15 centimeter graft. So that's a distance between the lateral malleolus to the popliteal fossa. So in a baby of 6 months, that's a maximum you can get from one lower limb. And that's a graft which has been put between the C5-C6 root and the anterior and posterior division. After we put this graft like this, here is a phrenic nerve seen going along the scalenus anterior. We put tissue glue on top. And this is a child at 5-year follow-up. As you see here, there is still weak wrist flexes, but reasonably strong finger flexion. So subsequent reconstruction was done. In many children, as seen in this child, we cannot get both the roots in C5 and C6. But unlike adults, even a strong C5 root or a big C5 root can give enough axons to innervate the anterior posterior division. Here, we separate out the suprascapular nerve and put a nerve spinal accessory to the suprascapular nerve. Use the C5 root to the anterior and posterior division. That is the tissue glue at the end of the procedure. And this is the recovery we can get. If you see here, all these children will have some minor corrections required at a later date. Most of the time they will need a derotation osteotomy for the external rotation and some amount of soft tissue release at the axilla for improving the shoulder abduction. A child with global palsy, again extensive graft put. Even if you put graft to the anterior and posterior division, lot of fascicles through the lateral cord will go to the median nerve also and give some amount of finger flexion. Rarely we find a child who has got absolutely zero median nerve recovery. So by doing intraflexural grafts, we can achieve a result like this and then go on to do subsequent secondary procedures. So this is the same child. You see, to start with, the finger flexion was very less or very nearly negligible, but over a period of 5 years, the finger flexion has gone to increase. Now we see a child who has undergone all the secondary procedures. So this child we saw at 3 months. At 6 months, we decided to operate upon the child. This was the intraoperative finding. This is a distal side, this is a proximal side. So there was a rupture of the C5 and C6 root. And that is after excision of the entire neuroma. That's the distal part. That's the posterior division, suprascapular nerve, and the anterior division. We put extensive nerve graft taken from both the lower extremity. Spinal accessory to suprascapular nerve transfer are also done. So if you see the timeline, 10 years, in 2010 we operated at 6 months, nerve grafting done at 9 months, and then Botox was given subsequently. Then we did a shoulder release at 2.5 years. Then we did a shoulder for external rotation of the shoulder at 5 years. So this is at 4 years, and this is the result at 5 years. So when we speak to any parent, we need to tell them that even if you do extensive nerve grafting, the child will require some amount of secondary procedures, and each of the secondary procedures will subsequently improve the overall function. So this is a timeline of the child from birth, 6 months after first surgery, the subduction after the first surgery, then release of the shoulder, and goes on to have a really good function. Now we come to late presentations and root avulsions. If we don't have any proximal root available, or if we see them late, as we have seen already the role of overlean transfer. Overlean transfer in children came relatively later than that in the case of adults. So in overlean in children, we find the structures are very small, but then under microscope we can easily co-opt them comfortably. So typically we use ulnar nerve fascicle for the biceps, the median nerve fascicles for the brachials. So this is a double fascicular transfer described simultaneously by Christoph Oberlin and Susan McKinnon. And you can get a very good result. So this is a child who underwent Oberlin transfer. So this is, we did not find any stump available, no proximal stump available. So spinal accessory to suprascapular nerve done, and distally double fascicular transfer done, and that's the result of the child. The child did not undergo any subsequent reconstruction. If we see them late, so this is a 13-month child. When we see the child at 13 months, we can do nerve transfers in children, just like in case of adults. In children, even up to 2 years, which I am showing the subsequent case, we can do nerve transfer. So spinal accessory to suprascapular nerve and double fascicular nerve transfer, and that is a result at 4-year follow-up. Even at 2-year follow-up, there is good shoulder abduction and elbow flexion. In children, when you innervate the suprascapular nerve, they get a really good shoulder abduction and even external rotation. That's the amount of external rotation seen here. So when we see them late, how late is late? Dr. Balakrishnan GD sir said that Alan Gilbert even presented 7-year exploration. The latest we have done is 2.5 years. So this is a 2-year-old child presented to us like this: no elbow flexion, no shoulder abduction and external rotation, but a reasonably good hand function. So she underwent exploration at 2 years of age. We did neurotization of musculocutaneous axillary and using long sural nerve grafts. So that's the exploration. That's it. This is a distal side. This is a distal side. This is a proximal side. And we did a long sural nerve grafts. And this is a result at 3-year follow-up. Then finally, you can also have failures in nerve transfer. Not that all nerve transfers go for successful outcome. So if you have a child who has undergone nerve reconstruction and got failure, then you should be prepared to do all the other ancillary procedures. This child did not develop elbow flexion. She had reasonable shoulder control. So we did a triceps to biceps tendon transfer. Triceps to biceps in children is extremely easy to train, and patients and the children get very strong elbow flexion. So what do the experts say? Poor shoulder and elbow function is not an urgent condition to need early surgery, that is within 3 months. We can wait up to 6 months to 11 months. Shoulder and elbow recovery were not different as seen in the Peter Water study, whether you do it at 3 months or up to 11 months. Even David Chuang in this chapter in Peter Nelligan mentioned the same thing. 6 to 11 months, if you explore and do nerve reconstruction, gives equally good results. The biggest advantage is it is easier to convince the parents that no recovery has come. And if any recovery, spontaneous recovery has to come, that will be seen by this time. Even patients operated more than 1 year. So if you see a child more than 1 year, you can still offer them distal nerve transfers and you can get good outcome. And there was similar improvement as you do in case of pediatrics. To summarize, in upper brachial plexus, we wait for 6 months. If co-contractions are there, we give Botox to triceps and further wait, and then do secondary procedures. If no recovery after biceps, then we do nerve transfers at 9 months to 11 months. In global palsy in children, when there is no hand function, you can wait up to 6 months, and if no hand function, we operate and do nerve grafting. Most of them will need secondary procedures, and we will see the secondary procedures in the subsequent presentation. Thank you very much.
Yeah, thank you so much, Jerry. It was a wonderful presentation of what nerve surgery can do in birth brachial plexus palsy. The key things are many of them recover. I think that's one point that we need to say. And unlike in adults where we say you have to take in very early, even when people come late, sometimes if you do nerve transfer, the nerve surgery, they get better. The reason being because it's a low velocity injury, some amount of recovery takes place and the muscles are not totally lost. The motor end plates are not totally gone. I think that's the point now where we are able to do this. And the next point is it's not a one-shot game and finish it off, because in children, we also have to take into account of the growth factors that happen with whatever we do and whatever the deficits that they have. So one thing which you highly highlighted was that most of the birth brachial plexus children will require and will improve with secondary procedures. I think that's what is important. Whereas the secondary procedures are not so common in adults, whereas secondary procedures almost become a norm in case of patients with in children. So the next talk will be by Dr. Praveen, because he has been traveling. He has given a recorded presentation. Now over to you, Balaji, for introducing Dr. Praveen.
It's a special thanks to Dr. Praveen. Its presentation is recorded here. Dr. Praveen Bharadwaj is a consultant in Ganga Hospital in hand and wrist surgery and Ganga Hospital. He had 109 publications He is a chief editor of Indian Society of Surgery of the Hand Academic Cell and editor of the Journal of Hand Surgery, Asia Pacific volume. We'll telecast the presentation is a recorded presentation.
Balaji, I don't hear the voice, Balaji. Girka.
They have the control. It's showing as muted. Balaji is muted on your side.
Balaji is muted, Balaji. I see a sign that is mute on the presentation.
Required for it. They could be categorized as primary or secondary. We know that the primary problem in birth palsy is the nerve problem. So whenever the operation is performed on the nerves, it is termed as a primary operation. Whereas the nerves very commonly recover over a period of time, but they do not recover perfectly, resulting in some muscle imbalance, which results in secondary deformities and over a period of time some bony effects of it. These deformities are called as the secondary deformities, and when we are doing operations to correct these secondary deformities, we term them as secondary procedures. The secondary procedures are required whenever the secondary deformities are there, which basically result from muscle imbalance, co-contractions, and growth over a period of time. Muscle imbalance and co-contraction being the two main important things which result in secondary deformities. We generally talk about that many of the birth palsy patients recover. Yeah, they do recover, but they still have some deformities because of the secondary deformities, and which are quite disabling, but many of them are corrected to quite an extent. The corrections can be required right from the shoulder till the fingers. Let us go one by one from proximal to distal. Shoulder deformities are the most common presentation in the clinic. They basically could be a limitation of abduction or limitation of external rotation of various combinations. The combination could be many. To just streamline the treatment modality in these patients, we follow this algorithm. We divide them into three categories: limited abduction with good external rotation. Second, where there is only limitation of external rotation with good abduction. And category 3, where both abduction and external rotation are limited. Let us see them one by one. The first category, where there is limitation of shoulder abduction, there could be a subcategory where the deltoid is working quite well. You can see over here, child has got limitation of shoulder abduction, but the deltoid bulge is quite nice. And we could very well see that there is co-contraction and tightness of the adductor muscles. These patients just require a release of these tight adductors and readjusting of the muscles in such a way that you can augment some amount of external rotation, where we transfer latissimus dorsi to the teres minor. And it gives a very nice result in these patients. This child at 2 years follow-up, we can see almost complete shoulder abduction, and this improvement is maintained in the 6 years follow-up as well. They also could get improvement in external rotation and reach to the head. This operation has been a very common operation with us, and we got a very good result with this operation in various age groups. Even patients who are little grown up, 17, 20, 24 years is the oldest what we've done, and they are also quite satisfied with the outcome. One of our outcome studies of the first 120 cases, we found that the increase in shoulder abduction was 76 degrees, with post-operative abduction rate being around 161 degrees, which is quite a good amount of shoulder abduction. The second category are the patients who do not have deltoid abduction. So here the abductors are This is the subcategory of one type where there is very limitation of affection based on rotation. When the tender is not working, the release alone is not enough. We need to augment the tender by transferring trapezius and tender. The trapezius to tender transfer works much better in children compared to adult, and we can get almost about 70-80 degrees of reflection. Another example, improvement in abduction. The second category is the patient with limitation of external. These patients again should be two types where there is limitation of external rotation, but passive external rotation is there. That is the category. For example, patient limitation of external rotation, but passive external rotation is present. They are good candidates for the latissimus dorsi transfer for external rotation, where we transfer into the first ligaments. And this is the kind of result we expect in such a patient. However, if there is no passive external rotation possible, as a principle, the tendon transfers may not work very well. In such patients, we take them for osteotomies. If the children are young and the CT scan shows mild retroversion of the glenoid, but the neural head shape is maintained, in that we do release of the subscapularis and
There's a block. Are you able to hear, Ari?
No, nothing is seen. I neither seen or heard.
Huh?
They are watching, I think it's their network is not strong. They will be seeing on the screen, but the relay from their network to ours is not there. Even the clarity was not good. So they will be watching.
Yeah. But do you think we can do it from here? You can't see the presentation over this, so we have it here. Shall we?
No, but they are already presenting it there.
No, I go to leave it.
Dr. Hari, are you able to hear
Yes,
me?
sir. Yes, we are able to hear. Yes.
So their connection is, we have lost
Every
their
year.
connection. Sir.
Every year, how many cases you see? Child.
Monthly we are doing around 40 cases, sir, now. Both adult and children.
Monthly, sir.
I think they started now. Taking the center one.
Satisfactory operation and gives a very nice improvement after the surgery. This is the basic plan what we follow. So if the deformities are passively correctable, they could be considered for tendon transfers. If triceps is good, we can do a biceps rerouting. However, if the triceps is weak, brachioradialis rerouting can be done. However, in general, most of these patients by the time they present to us have fixed deformities and do not have a lot of suitable donors available for transfer. Hence, most of them are good candidates for doing a radius foundation osteotomies. This is quite a reliable operation. We can tailor it to the need of the patient, get a perfect amount of anterior posture of the forearm. We try to get about 20 degrees of pronation, and immediately it will improve the appearance of the child. You can see from this posture, appearing posture. It also improves the function. So patient is able to go and pick up object and also reach glass. And it dramatically improves the tabletop activities. You can see a child over here trying struggling to get his hand over the one there. But once the forearm is positioned in a perfect position, he is straight away able to go and lift up things. Now, to summarize, the secondary deformities in birth palsy are quite common, and they result in disability in these patients. Fortunately, many of these disabilities can be corrected to quite an extent, but all these patients would require a detailed assessment and a tailor-made plan for each of the child so that we can perfectly cater to their demands. However, most of these children can be made better and we can help them to do what they want to do. Thank you so much.
Thank you so much, Praveen. You summarized what the message that is really has to go in the sense in birth brachial plexus palsy.
I'll be talking about secondary procedures in birth brachial plexus palsy. When we talk,
I think the idea is in secondary brachial plexus palsy, most of them can be improved. And as Praveen said in the last slide, detailed assessment is the key, so that we could find out now what procedure could be made suitable for them to improve their functions. So that brings to an end, the series of fantastic topics presented by very experienced people. Now I will hand it over to Balaji to summarize and the sessions, and if he's got a case report to present, and that will be the end of our session. Thank you so much, Balaji, and over to you.
Is it visible, sir?
Yeah.
Yeah, it's our present, just 3 cases of presentation only, sir. Just starting presentation. The priorities of the reconstruction brachial plexus palsy is based on the assessment of what we needed functions are both most important and likely to be successfully restored. The first one is restoration of elbow flexion is the highest priority, followed by shoulder stabilization and external rotation, grasp and release function of the wrist and fingers, hand sensation, and the intrinsic hand functions. You have the first case is a 52-year-old male patient with pan plexus palsy due to road traffic accident 4 months duration. Had a left side at palsy, atrophy of shoulder, biceps, and hand function. He had a pliable upper limb except active contraction, minimum contraction in the FCU, and flexion of the ulnar 2 fingers, the wasting of deltoid, biceps, triceps, forearm, and hand function. And MRI findings shows a stretch injury with a dense scar tissues around the supra and infraclavicular plexus. We take the patient for surgical procedure and neck exploration, complete neurolysis of supraclavicular and infraclavicular plexus. And because of that, ulnar nerve is working, we did one fascicle to that now to biceps. After one year after that, we had a fall and a fracture of that radius, distal radius. At the same time, that wrist osteogenesis was done. This is 15 months follow-up that he is able to abduct that because of neurolysis, the abduction of that shoulder is improved, and that biceps deltoid muscles, the mass is improved. The pectoralis major strength improved, biceps contraction is present but not strong enough to flex the elbow. So we tried to plan for a pectoralis major muscle transfer for elbow flexion. This is a marking for that pectoralis major muscle. Muscle was harvested. This is the technical aspect of the muscle elevation and neurovascular pedicle. The bipolar muscle transfer was done, attached to the acromion, and the distal end is attached to the biceps tendon. This is the 5 months follow-up. The contraction of the pectoralis major started. This is the video presentation. It's able to abduct the shoulder. Then that as a contraction is doing that active contraction of that transferred by a pectoralis major muscle. Another second case is C5 C6 root avulsion with stretch injury of C7. Is had a wasting of supraspinatus area, infraspinatus, deltoid, and biceps. The triceps is M4 power, shoulder abduction is nil, and elbow flexion nil, and elbow extension is M4. The wrist flexion and extension M4, and finger flexion and extension M4. Sensory deficit in the deltoid and lateral aspect of forearm. Distal pulse fed, no harness. This is the MRI finding shows that a stretch injury of entire brachial plexus, avulsion of C5, C6 roots, and the X-ray shows normal diaphragmatic function and blood investigation within normal limit. 1 minute.
It is going okay, Balaji. It is going okay.
Yes, sir, fine. We did a spinal X-ray now to suprascapular nerve transfer, and then 2 fascicles of ulnar nerve to biceps opulent transfer done. This is 8 months follow-up. Contraction against my resistant of the biceps contraction. Shoulder abduction was so the final case, it's infraclavicular brachial plexus injury. Had a patient with infraclavicular brachial plexus injury, fracture humerus and brachial artery injury, and rupture of median musculocutaneous. He came to that OP emergency with the shock. He took the patient for humerus fixation, and then radial artery, brachial artery repair was done. He had a complete flail limb at the time. After 3 months, that neuropraxial component was improved. This is the finding. This is that. Sorry. So you had not able to flex the elbow, wrist and finger drop is present, ulnar nerve sensation is improved, then FCU and the medial 2 fingers active flexion is present. The deltoid, triceps and pectoralis muscles are great price. So the plan was median nerve repair by sural nerve graft and the LD muscle transfer was there. This is that nerve gap is present of median nerve. So biceps is atrophied and fibrosed. So we did a muscle, LD muscle was harvested. It's with neurovascular pedicle transferred with the proximal fixation to the coronoid process, and distal end is anastomosed with repair with that biceps tendon. The sural nerve graft for median nerve repair. This is a final insert of that LD muscle. This is a 3 months picture. He is able to lift that 2 kg weight, and then after the nerve repair, he is able to do that finger flexion. This is thumb movement, and sensation is improved in the hand and the thumb, finger and thumbs. So this is that. Sir, this is our limited experience in our institute. So this meeting gives an eye opener to us to improve that our approach to the brachial plexus and make our skills to a higher level, sir. Thank you very much, sir. It's giving to that Dr. DEVADOSS sir to give a remarkable.
On behalf of the IORAS Old Boys as well as our DEVADOSS Hospital, I am very much thankful to Raja Babadi for having arranged a wonderful experience and also eye-opener for all the brachial plexus injuries. And many of us did not know so much about it. But today I learned quite a lot. That's why I always tell my students that every day we learn. Similarly, even at this age, I learned quite a lot today from Raja Babadi and his team. And I am very much thankful to Raja Babadi and all the speakers who has taken time to prepare this paper as well as present an excellent manner so that we could understand what exactly is being done and what exactly we can do for the patients as well. And their morale can be increased to a higher level. In that way, we are very, very lucky to be to have had this opportunity to have the brachial plexus symposium, so that all our old boys as well as other participants who are in the online, they are all benefited with this wonderful program. Thank you very much, Raja Babadi. We'll send you the mementos for all the speakers and you especially for having done a wonderful job. And we are very, very, very much thankful to you, Raja Babadi. Thank you very much.
So thank you so much, sir. I should start thanking our teacher, Professor Harvey, for staying on all the course. I think I have been watching, and one of the things which inspires me is from both of you is that you never cease to learn. That's the amazing thing, sir. And there's one of the things which you also found with Dr. G. Balakrishnan. He used to tell Dr. Hari and all the fellows of our team, when many of you are tired and listening, but then you'll always find some questions from Dr. GB or from Professor Avi stating what's happening, what's new. And it is that spirit of enterprise which keeps us all going. So thank you so much, sir. And I also thank Hari and Praveen for helping me to put up. I think they who contacted the speakers, and thank Veena, Terence, Anil, and Sunil for also joining us. And I'm sure it has been an eye-opener. It should have been an eye-opener for many, as it was to us a few years ago. I think just a few years ago, we also didn't realize that how much could be done. And I still remember the day in Hotel Breeze when Professor Harvey organized the first meeting, where it was an eye-opener that these things are all possible to see. So thank you so much, sir, and we wish you very well. And hereby probably we close this session, sir. But Professor Venkateswamy say, sir, would you like to say anything, sir?
Are we, sir? Venkateswamy sir, thank you very much. Could you like to say some words, some advice?
Sir, you are muted, I think, sir. It's not coming, sir. Voice is not coming, sir.
Thank you, Rajasabhavati.
Yes, sir.
You know the famous Tirukkural, எப்பொருள் யார் யார் வாய் கேட்பினும் அப்பொருள் மெய்ப்பொருள் காண்பது அறிவு. From everybody, whatever new thing they say that. I really congratulate you for the excellent work you are turning out. Thank you all very much. God bless you.
So thank you so much, sir. Thank you, sir. Thank you. Bye-bye. Bye-bye. Bye.
Thank you so much.
Bye.